So good morning, all of you. We are glad to have entered Bout 22, a session on imaging and ISR. Here we have a case to be presented to you, a 55-year-old man with NSTEMI and instant restenosis of 95% of the proximal LAD segment with a 4x22mm stent implanted about 9 months back. We are not told the make of the stent. His eGFR is 45 ml per minute per meter squared. We know that he has a mild compromised renal function. So what would be the preferred mode of imaging during revascularization? We have two expert speakers to share their views with us. Dr. Chirag Seth will be going to talk to us on HD-IVUS, and Dr. Mahesh will talk to us on OCT will be the preferred modality. First, I would like to invite Dr. Chirag Seth to share his inputs on how he is going to use IVUS as the preferred modality in this case to treat this complex patient. Dr. Chirag Seth, your podium is yours. His credentials you've all seen. He is a dignified illuminatory in this field. As you can see, the credentials projected in the field. Thank you, Dr. Chirag Seth, it's yours.
So, good morning, everyone. Thank you, Dr. Kamal Sharma, for inviting me for this debate. And straight away, I think we have been introduced with the case, and I'm going to focus on the discussion about HD-IVUS, whether how preferred it is in the view of proximal lesion with an altered renal function. So, having known about this case of an early stent failure, proximal LAD ISR with 4x28mm stent at 9 months, what do one wishes to know more? What is the data of index PCI? What was the indication of index PCI, acute coronary syndrome or not? Type and generation of a stent, whether it was bare metal or a drug-eluting, first generation or a third generation, DAPT and statin regime, whether the patient is diabetic or not, and whether imaging was performed in the index PCI or not. I think each and every point is relevant because all of them at some point of time are going to decide about the early MACE rates as in this patient. We know now enough that the prospective use of imaging during index PCI improves clinical outcomes. We have data from ADAPT-DES, one of the largest prospectively randomized trial, wherein almost more than 8,000 patients were clinically followed up at 1 and 2 years. And we know that IVUS tends to translate into longer stents, larger stent diameters, and higher inflation pressures in almost more than 70% cases. And it did show that there was significant reduction in MI, stent thrombosis, target vessel failure, and it impacted clinical decision-making in majority of patients. So there is no doubt that IVUS is superior versus the angiography alone in guiding the PCI. And there have been concordant data from many other trials where IVUS guidance led to reduction in the MACE rates by 41%, mortality more than 50%, and ischemia-driven TLR by 40%. We know that the common causes of instant restenosis are going to be either stent under expansion, deformation, or a stent strut fracture. There could have been a geographic miss, and there could have been probably an erroneous landing of the stent into the endothelium where there is more than 50% plaque burden, leading to age restenosis. So now what do I want to know from imaging in this patient? I need to know more than just MAC or under expansion. We need to know what is the plaque volume, morphology, residual plaque burden at stent ages. We need to know about extent of calcification it was there, whether there was stent fracture or not, and what was the eccentricity of the deployed stent. And then the question arises, IVUS or OCT. We know this famous slide where it has been shown that there are a lot of similarities between IVUS and OCTs, and in majority of things, there is a lot of concordance between the two imaging modalities. If you focus on the follow-up part, then the IVUS little legs behind it, especially for stent fracture and stent malposition. But otherwise, there is a lot of concordance between the two imaging modalities. In general, it is understood that in view of better resolution and intimal surface details, OCT is favored more versus IVUS, which has got a better penetration, and therefore it can detail plaque volume, morphology, residual plaque burden, and vessel sizing much better than OCT. And of course, vessel sizing is supposed to be much better with IVUS and much more perfect compared to the optical coherence tomography. So if you want to look at MSA or under expansion of the stent, both modalities may be equivalent. Deciding volume, plaque burden, vessel sizing, IVUS would be better. Looking into calcification, malposition, and stent fracture, OCT would be much better. And when it comes to the factor of instant restenosis, vessel size which is so large, 4 into 28 millimeter, stent was implanted, so naturally the vessel size is higher than 3.5 millimeter. And there is presence of impaired GFR in the given patient. In that case, the decision tilts towards IVUS. Up till now, whatever the limitations of IVUS was that the resolution was not as good as optical coherence tomography. But now with the HD-IVUS coming into picture, the lateral resolution of HD-IVUS or high definition intravascular ultrasound, it tends to approach to the resolution achieved by OCT. This comparative slides shows it. And therefore, the problem of impairment, little lesser resolution that is solved with the help of HD-IVUS, and it is now equivalent to the OCT. There have been comparative studies published where co-registered HD-IVUS images and OCT images have been studied in native and stented coronary arteries and segments, and there has been a lot of concordance for both the imaging modalities. And therefore, we can see here that the thin cap fibrous atheroma, when you see in OCT versus IVUS, you can see that image resolution is comparable and in fact much better as far as the penetration of the imaging is concerned with the HD-IVUS. If you see the extent of plaque burden, again, we can see that yes, the images are comparable with a better penetration. Stent malposition, again, the images are comparable and both are fine. So do we have any head-to-head comparison of IVUS and OCT? Yes, back in 2012, we had 70 patients randomized compared to IVUS and OCT. And it showed that IVUS guidance was associated with greater stent expansion and smaller stent age plaque burden compared with the OCT. Opinion had shown that there was trend towards larger maximum volume diameters and larger instant angiographic minimum lumen diameter. And there was less contrast use in IVUS versus OCT, which approximates to a median of about 20 ml with a range extending up to almost 65 ml. So over a period of years, whatever principles we have learned from IVUS and when they have been applied to OCT, it has been now shown that the results of stent expansion derived from OCT are almost comparable to what the IVUS could achieve, and therefore OCT is almost non-inferior to the IVUS. If you focus into the instant restenosis assessment with OCT, with one of the other important modality, that is angioscopy, it has been shown that OCT analysis used to underestimate instability of the instant restenotic lesion, especially when the OCT is defined with non-lipid rich plaques. So OCT still lags behind as far as the vulnerability is concerned when it's compared with the coronary endoscopic findings. So it would have, despite a good resolution, it would still have some limitation as far as understanding plaque morphology is concerned. So my concern for use of OCT in this patient would be that the patient had 90%, 95% ISR in large vessel proximally with a non-standing, and therefore presence of thrombus is the rule. A subtotally occluded vessel may have some optimal contrast clearance for optimal imaging with the OCT. There may be some risk of thrombus migration distally with contrast clearance for imaging. Impaired GFR up to almost 15-20 ml probably is not a major factor against the use of OCT. One can use Dextran also. And but yes, we have to understand that when you have a baseline impaired GFR, risk of contrast-induced nephropathy goes up by almost more than three times. And therefore, one would be a little reluctant or maybe cautious in using OCT, especially when you have HD-IVUS available compared to the routine IVUS. And definitely, plaque morphology and volume assessment at stent ages is more important in this question, hence the choice of HD-IVUS over OCT. And not to forget that the Dragonfly Optis imaging catheter, the Abbott website itself shows it is not intended for using vessels 2 to 3.5 millimeter in diameter. So better we respect that instruction provided here with. So the conclusions for the talk would be that HD-IVUS and OCT will have comparable near-field resolution in our state-of-the-art in intracoronary imaging from 2019. HD-IVUS can visualize fine structures with better depth and no contrast compared to OCT. And HD-IVUS, unlike OCT, can be used in renal insufficiency. And HD-IVUS would definitely show all histopathologic stages of atherosclerosis, including thin cap fibroatheroma. There is some role that, yes, because of better penetration.
Sir, time's up.
Yeah, this is the last time. Early stent failure and ISR, HD-IVUS is preferable. And even when final details and resolution are better with OCT, bulk of clinical data will favor IVUS. The question need not be HD-IVUS versus OCT, but question should be appropriateness of angiography guidance alone versus imaging guidance for PCI in stent failure. Thank you for your patient hearing.
Fantastic talk, Dr. Chirag. I think you've taken clue from everything that I've mentioned in the case. 4 mm or be it proximal or the eGFR. I mean, the odds were very much against IVUS, but with HD and the kind of case that we choose, we wanted to create a debate. And I'm sure Dr. Mahesh has got his own counter to it. Over to chair, Professor Justin.
That is fine. I think we'll listen to
the second talk. Yeah,
we'll listen to Professor Mahesh, and he's going to talk to us, as Dr. Kamal has said, about OCT will be his preferred mode. And after his talk, we can have the discussions.
Thank you again, Dr. Kamal, for this wonderful opportunity. Eternally grateful. Dr. Chirag, you are very insistent on saying how bad OCT is, on not saying how good IVUS is. So it's cool by me. So I'm restricting my presentation to plenty of images so that I can try and drive the point home. Readings from the 73rd Apollo. So this is the bottom line. Macrophages, lipid pool, necrotic core, sheet calcification, nodular calcification, fibrous cap, fresh thrombus, organized thrombus, media. Practically OCT beats IVUS hands down, even when it comes to an HD-IVUS. ILLUMINE 2 was 2015 study. Now we are in 2021. We have moved forward a hell of a lot. So this is the basic comparison for anybody who would like to define what are we trying to miss by using OCT versus IVUS. Point 1. Point 2, this is how the TLF, target lesion failure, looks like. A homogeneous, bright, uniform layer, exactly the way you cannot, histopathology equal to the OCT picture. Neoatherosclerosis with intima, with heterogeneous composition, instant necrotic core, lipid calcification, foamy macrophages, and neo-intimal proliferation and vessels, vasculature. This is there. Third is stent under expansion, and stent area is significantly reduced. You can see the stent is reduced. It is almost like a histopathology slide. Point number 1. Point number 2, there's nothing as only one will be the manifestation of ISR. It will be usually a combination of all these three. So you should have clear pictures to identify whether it is atherosclerosis with a stent under expansion, or stent under expansion with neo-intimal hyperplasia, or areas of neo-intimal hyperplasia with atherosclerosis. OCT stands out. This is a fact which I had presented last month. In real world use, modern does fare even less with 5-year target lesion failure. That rate increase, that is more than 15%. So even in non-image guided stenting, 15% of them fail by 5 years. So we are going to be dealing with a lot of ISR. If immaculately well done, it comes down by 4%, it is 11%. So every 100 stents you implant today, 5 years down the line, 11 of them will come back to you with ISR. So you have to be geared up for ISR. You can't just wish away ISR. So this is the LAD. I'm just now going to show only images. This is the LAD post mid LAD. So that I want to clarify the concept of the sizing and this thing. So what all I can see, this is the stent in the mid LAD. It shows me a distal edge. It shows me an embedded struts, proximal edge, fibrous plaque, and distal left main with a clear-cut vessel diameter of 4.12. So 3.5 is a company-defined restriction, but it is not the actual case. We can go up to 5 millimeters easily. You can also see the diagonal ostium. You can also see the ostium of the circumflex. Here you can see all the dimensions wherever you want to see whether there is dissection because of your post-dilatation, all the MLAs, all the diameters, everything. And this is the tightest part showing left main proximal diameter of 2.41. So left main can be seen. This is the post-stenting. This is a circumflex stent. You can see one stent in the circumflex, overlap, second stent in the circumflex. This is the decay crush stent. Can you see the 4 struts which is outside into the LAD left main? Those are the struts where you got to enter carefully. So all the proximal opposed struts, all the struts of the circumflex can be seen. This is proximal circumflex. This is the run from in the same patient. From the LAD into the circumflex, into the left main, you can see the opening of the diagonal. You can see this left circumflex with a lot of struts hanging over. You have to be careful. All the red areas in OCT means you are in trouble. and this is the left main. So this is the pullback of the same patient, LAD. After the LAD to left main stent, everybody says LAD left main cannot be imaged. No, left main can be imaged. You can see the circumflex opening here. This is the left main, and left main diameter here is about 4.5 millimeters. So what else can I do? This is a 3D facilities that I have in the OCT. I can show all the side branches. I can show guide wire 1. I can take it away and put guide wire 2, or I can show all of them together. So I can have a tissue mode, a lumen mode, a stent only mode, a fly through mode. You name it, we can have it. It gives you more information. Third point I would like to stress is about angiocoregistration. For those people who are not aware, this white dot is exactly where the catheter is being pulled back. You can co-register the angiogram with the OCT, and you know exactly what you're dealing with. For example, if you have an ISR, if you have put in a stent, you can see these red areas of red marking, which is inappropriate stenting. And you can see that at the ostium of the diagonal, there's a red mark, and opposite there's a red mark. This is the area where to go and post-dilate. If you don't post-dilate area, so it's going to give you which is the area which is under-dilated. It is also going to tell you where is the area you got to post-dilate. Okay. Now, what all, once the stent has been deployed, it shows you in 4 different words. This is the red areas across the stent reconstruction. This is the side bar which shows you green, white means clear, red means more than 300 microns of difference between the stent and the vessel wall, and yellow means more than 200. You can see it in angiocoregistration. You can see the red marks, you can see the white marks, and you know that you are not opposed well. If you're still not sure, you take a cross section. You can see all these red flows floating. That means you're not done a good job. So in this case, Dr. Sharma has put in another Gundi which says it is eGFR is 45 ml per meter square. What is the solution? You do a saline OCT. You don't use a contrast, you just do a saline OCT. I will show you 2 pictures. This is the top, you see the contrast picture. Bottom, you see the saline picture. You see, unless you look carefully and find a few speckles of RBC inside the saline picture, you will not be able to differentiate which is the better quality contrast of the saline picture. What all I can see, 360 degrees EEL, saline, and this is where fibrotic patch can be seen. The area can be calculated, the diameters can be calculated, and the length can be calculated. All the areas which are very tight are shown in red, and the left main is shown in huge. Left main can be seen. 4.27, 4.35. 12.31 is the area, 12.4. So there is hardly any difference, less than 0.1, less than 1% difference in the area in the calculations. That is 5.93, 5.42, and 1.94, 1. So even the vessel dimensions and area is not being affected. So if you still want to use HD-IVUS, I have nothing to say. I rest my case. Thank you.
So thank you, Dr. Mahesh. All of you will agree that we had a wonderful time of discussion. Dr. Chirag and Dr. Mahesh, they have clearly spelled out their points. Dr. Chirag shared to us that how, in fact, with the IVUS, he'll be able to get the vessel sizing better, and particularly a larger vessel where IVUS will be superior to OCT. And he also talked to us about the ability of IVUS to better delineate the plaque volume and morphology. And in fact, because the renal function unit is compromised, IVUS can in fact have a zero contrast angioplasty. And he also talked about that with a high definition IVUS, we can have a resolution of up to 22 microns, which almost matches what you're going to get in OCT. So Dr. Mahesh did not stay behind. He came back with a full vigor. That all of us will have to be prepared to manage cases with instant restenosis. Almost 11% of them is going to come back in 5 years' time. And he showed very good images of left main, where 4.5 millimeter of left main was imaged very nicely with the OCT. And he also highlighted the fact that IVUS and OCT have a very good, they have the co-registration facilities. So the ability to pinpoint the place where you can treat or available. And lastly, he pinched the nail on the coffin that when there is a need for contrast, you can still manage very nicely with saline. So all of us are really now confused as to what to use at this point, IVUS or OCT. So Dr. Chirag, let me ask you that if he can manage everything by saline without an OCT, with the contrast, he can safely manage a CKD patient, And he can also see a very 4.5 millimeter left main. So with this take home, what will be your comment on this?
Let me tell you, the last slide of my talk was that over the advancements that we have witnessed in OCT as far as and the IVUS is concerned, I think whichever modality you are comfortable with, it is okay to use, whether you are comfortable with OCT or IVUS, but use some imaging compared to no imaging when you encounter stent failure. And the only thing IVUS would probably give better would be the extent of plaque burden and the sizing of the vessel. That is the only thing which probably IVUS is always going to be superior than the OCT. Because of better resolution, definitely the extent of imaging and the clarity of image would be definitely better with OCT, no doubt about it. And therefore, the debate should be that some form of imaging in stent failure is mandatory compared to no imaging, and therefore the debate should be no imaging versus imaging rather than OCT versus IVUS.
So thanks, Dr. Chirag, for the wonderful comments. Now I'll put the question back to Dr. Mahesh, that the larger size that Dr. Chirag said, now the stent that was deployed was 4 millimeter. We do not know if the vessel was 4.4 millimeter. And with this Glago phenomena taking over, the vessel could have enlarged in size. Will the OCT imaging compromise the intervention at this situation? And the second aspect of it is, if you can manage with saline in every case, why is that people use still contrast? Why can't we manage every OCT with saline? Sir, Dr. Mahesh, you are muted. Can you unmute yourself, please?
Yeah, the first part in real world, we can see up to 5 millimeters easily. And with a little bit of bias, wire bias, you can image it very well. And since if you are using saline, the number of runs doesn't matter. You can keep repeating it till you get the image of your satisfaction. Now, there are 2-3 points I would like to say about saline. A, you cannot have OCT co-registration with saline. It can only be done with at least 1/3 contrast with saline combination is what I'm trying out. I'll work that out and see if I can get it done. So I have a definite drawback when the vessel size is more than 5 millimeters, 6 millimeters, 7 millimeters, impossible to image. I agree. If you have a proximal LAD, which is 4.5, 4 millimeters, you can always use a guide liner, pass your OCT catheter through the guide liner and wedge the guide liner at the ostium of the LAD and then take a shot, you'll get a much better picture. Saline is something that you got to get used to. What I do is, as a protocol, I always try saline first. I'm not successful in all the cases. Sometimes saline just doesn't give me images, in which case I quietly switch over to contrast. So in this bargain, I'm trying to fine tune my methods in which I can use saline in majority of the cases. About 70% of the cases, with or without the help of a guide liner, I'm able to use saline as per OCT medium. So these are the two things I would like to say. And I totally agree with Chirag. The 15% TL target lesion failure can be brought down by 4% if you do proper imaging, not only in TLR cases, even in the original cases where we are doing primary angioplasty, the original native vessel angioplasty. If you do imaging, you can bring down the TLF by 4%. So imaging is mandatory. Imaging as far as possible. It's absolutely mandatory in left mains and bifurcations, so that we'll be able to give a better result and the TLF can be reduced. Again, the concept of imaging with ISR angioplasty and no imaging with ISR angioplasty, again, will not take off. It is not fair. That's what I felt.
Thank you, Dr. Mahesh. Now I invite comments from my co-chairpersons and moderators, Dr. Tejas Patel, Dr. Joel Shah.
Yes, I think this particular case, both stood perfectly well. And but I do agree when complex cases are done, imaging is a modality to be taken up hand.
You are muted, Dr. Joel.
Yeah, can you hear me?
Yeah, now we can hear you.
Yeah, so complex cases, definitely imaging is a gold standard nowadays, because bifurcation stands, we don't know hanging whether it's apposed or not. So imaging is much needed, first thing. Second, regarding the use of contrast, I very well agree with Dr. Mahesh that simultaneously using saline will reduce it, particularly when GFR are less. Otherwise, OCT also stays fair when the vessel size is very high. So overall, very good presentation by both of the presenters. Thank you very much.
Now, may I invite the moderators to give their comments, Dr. Parminder Singh, Dr. Tushar, Dr. Prakash. So we all had a very good discussion, and in fact, how would you combine physiology with this imaging? Now, the concept that we have is physiology should let us know when to treat and where to treat, and anatomy should let us know how to treat. So, what will be a comment on combining FFR in these patients? Dr. Chirag first and Dr. Mahesh, FFR and other diastolic flow reserves.
I mean, this patient clear-cut has a stent failure and a non-STEMI. So I believe FFR probably does not have any role in this kind of patient. And probably FFR combining with imaging may have a role much better as far as left main lesions are concerned. And definitely physiology should be given a chance first as far as deciding appropriateness of the intervention is concerned. But I think that stands true for most of the chronic stable ischemic lesions, or especially when one wants to find out culprit lesion in the setting of multivessel disease. Probably the setting of this patient, I don't see the physiology as a major important factor to decide. It needs intervention and needs correction of the stent failure. So.
Thanks, Dr. Mahesh. Any comments from your side?
Can I change sides?
Sure.
So the IVUS has got the new form of IVUS has got a fabulous thing. It is called angio-co-registered intravascular ultrasound with tri-co-registration with the FFR. So you get FFR, you get IFR, you get angio-co-registration, and you get the IVUS images all on one place. So you can A, identify your position of the lesion by co-registration, B, identify the lesion extent, and C, identify simultaneously which is the lesion which needs to be tackled. So that is the new one that has come. When it picks up, it will be a challenge. But OCT is not far behind. OCT has also come up with the co-registered OCT with IFR, and that is also, so you can do the newer modalities of imaging, whether it be IVUS or OCT, have got integrated IFR in them, and that is the way forward.
So thank you, Dr. Mahesh. All of us will agree that we had a great time of discussion. The essential take-home points that we have had is we understood the indications of this imaging. All of us agree that this case definitely needs a form of imaging. And we always choose the imaging which we are comfortable with personally and we are well versed with. And it is always good to use both IVUS and OCT in a complementary way, understanding the limitations of each. And in CKD patients, unless we are very talented like Dr. Mahesh to pick and choose which to get good images with the saline, we probably can go by the side of IVUS. And in case of very larger vessels, when we really have doubts.
The time is up.
Yeah, fine. So thank you very much for the nice time. Thank you, all the faculty and the team. Thanks a lot.
Thank you, Dr.
Mahesh.
Thank you, everyone. Thank you. Thank you, Chair, moderators, and the speakers.